us a little bit then what your initial session with a patient or client would look like. What types of test measures are you doing? What sort of evaluation techniques are included?
Yeah. So the biggest thing that I am doing to get kind of my bearings with a case is in my physical exam. So I'm looking at things that normal medical neurologists would look at, but I'm looking at the subtleties of that. So for example, if someone's going to touch their nose, in the medical neurology, we may be thinking like, oh man, that's kind of what we're looking for. But I'm looking for like these little subtle ones. Or what happens if are they fine in this context, but as soon as I have them think and do it, do they break down? Or if I have them turn their head and do it, do they break down? Or if I have them stand up. So I'm looking at, like I said, taking it for a test drive. But then that's really hard for patients to be able to embody. For me to say, oh yeah, I did this and your eyes did this funny thing. And they're like, I don't know what that means. So we use just some kind of very simple things that are available to everyone. We use video oculography to record and look at eye movements so we can measure them. So we're measuring, we're using metric units to be able to track and say like, all right, so if I lose gaze at 4 degrees or 6 degrees and I'm getting square wave jerk amplitudes of 1 degree and they're happening at a frequency of once per second. And then we can use that as a marker to say, can we do our thing and find that their gaze amplitude gets bigger and their square wave jerk count goes down and their eyes become more stable. And we use that as a measurement tool. So I like VOG a lot. I think it's my favorite. I like it better than a lot of the eye tracking.
Can I ask what system you use? I just want to nerd out a little bit. What system are you using for your?
My favorite one is, I have a couple. My favorite one, I'm going to get in trouble, but my favorite one is the micromedical unit.
Okay. Is that the visual eyes or is that the original one with the monocular view of the camera?
You got to use a binocular because, as you know, you got to be able to see those little tropias and phorias that are happening in different pupillary changes. So I like a binocular one.
Is that the visual eyes of the glass tabs, or is it with 2 individual cameras?
It's the glass tabs, and then the cameras come from the top.
Yep.
And they project down. And then I also have a pair from Neurokinetics. You can see over here. They have a really great one too, very similar model. I actually have one of those. So I have like a crazy vestibular chair. You guys should come nerd out about it. So I have a chair that's like a combination whole body rotation chair. So in the vertical axis, and then in the yaw axis, and then also we can do a measure of, so we can turn people and do it roll, which is pretty cool. And then we can move it eccentrically, so I can isolate over one ear, so I can put the axis point, I can move it over 4 centimeters and drop it right on that ear, so I'm getting a centrifugal thing. It's got array on it so that I can do VOG in it, and it's got calorics in it. It's way too fancy, but it's super cool. But that one, I have a neurokinetics unit that's in that, and I actually use that one when people are rotating and we're doing therapeutic things, so I can watch exactly what's going on in their eye and I can capture it. So I have those ones. We use some eye tracking. I like to see, so for me, this is getting super nerdy, so I apologize if anybody needs to go to the bathroom, this is the moment. But it's super helpful because that's becoming a very popular way to do it because we can really simplify things for people. But I don't like it because we can't calibrate based on any video recording. So when I look at my VOG software, I can see their eyes on the camera, and then I can look at the tracing that we have. So I can see if there's any artifact, or if all of a sudden it's not rendering my pupil, it's rendering an eyelash or something like that.
You're not relying on the software, you're relying on your visual, yeah.
So I can visually interpret it, and then we can have something to show people to be able to say, here's our metric, here's where we're starting out, our baseline, can we improve on this? So that's my personal preference. With a lot of eye tracking software, we just don't have the video, so I don't know if it's tracking what it says it's tracking or not. And we use a CAPS force plate for posturography, which is the best. I know the standard is using a neurocom. We've kind of learned that that's not the thing because we've got this kind of remembered aspect of being in. So when we're in the cage, right, or we're suspended in the harness, we operate differently. It's kind of like, when you close your eyes and there's a chair over here, you're more likely to fall toward the chair. So it changes our center of pressure readings. So what we do is we use a CAPS unit that's just on the floor, and it measures our posture and our sway parameters in on z-axis and x and y. But we put it in the middle of the floor, so there's nowhere to go. So we're seeing a true variable of when I turn my head, am I actually pitching this way, or I just freak out and reach toward the wall? So that's super helpful. And then we use, like I said, I have that chair that we use. I like to use pupillometry. Great app for anyone that's diving into pupillometry is, have you guys used the Reflex app?
Not yet.
It's amazing. I have like the expensive one you put up that you have in a hospital. I have one of those and it's in a drawer because I like the app better. It runs through my phone, and it just uses the light from your phone, dials you right in, and then you can get an actual waveform of what's happening with their pupil.
Oh, interesting.
Technology, I really like it a lot.
It's called Reflex?
It's called the Reflex app. It's on, I use an iPhone, so it's on iOS. I don't know. If we're outside iPhone, I'm not very helpful. So, but yeah, I like to use those. And then from there, it's just like good old fashioned, neurological testing equipment using, we use some neurooptometry stuff with Maddox rods and some different things. But otherwise it's stethoscopes and reflex hammers and pinwheels and all the good stuff.
So very objective. You like to get a lot of data in order to compare and track your patients as they go through recovery, not only subjectively, but also objectively with what you collect.
Yeah, we got to know if it's working fast, right? So if you're thinking about brain and you're thinking about neurons, like the half-life growth of a neuron is super, super fast. We're in the millisecond range, right? So we should know pretty quickly if we're trending in the right direction. And if we're not, then we either have to change something or not do it, right? So that's a big part of what we do is kind of that proof of concept, is making sure, this is what we found. Here is what we think will stimulate that area the best within that metabolic capacity. And then we put it to the test. And if it works, then we'll see a change in our diagnostic tools. If it's not working, then we got to do something different. And I think it's humbling sometimes, because sometimes you don't nail it the first time. But I think it's super useful, and I think it's the right thing to do for people, rather than getting, down the line and going, I don't know, I hoped it would be better.